If you are over 60 and taking medication for your heart, your blood pressure, your mood, or your sleep, there is something your prescribing doctor almost certainly never told you. Some of the most commonly prescribed drugs in the world have a direct effect on prostate tissue. They change the way blood flows to the gland. They alter hormone signaling. They interfere with the very biological mechanisms that keep the prostate healthy and regulated. And the result for millions of men is that they are managing one condition while quietly accelerating another. Waking up 3 times a night, sitting on the toilet waiting for a stream that never comes. Watching their erections disappear and being told it is just age. It is not just age. In many cases, it is the pills in the medicine cabinet. I want to be very clear before we go further. I am not telling you to stop taking your medication. That is not what this is about. What this is about is information your doctor does not have time to give you in a 15-minute appointment. Because when you understand what these drugs are doing inside your body, you can have a real conversation with your physician, you can ask the right questions, you can make informed decisions, and you can take steps to protect your prostate while you manage everything else. That is what I am here for. I have been practicing urology for 5 years, and the pattern I see most consistently is this. A man comes in with worsening prostate symptoms. He is doing everything he has been told. He is going to his appointments. He is taking his medications. And yet things are getting worse. When I look at his medication list, the answer is often right there. Nobody connected the dots for him. Today, I am connecting them for you. Before I get into all 6, I want to point you towards something. I have put together a detailed breakdown of the root cause mechanism that drives most prostate problems after 60, and why so many men find that managing their other conditions actually makes their prostate worse over time. I have linked it below this video. It is the most important thing I have published on this channel. Watch it after this one. But let me give you the foundation here first. The first drug category is antihistamines, the older generation ones specifically. Diphenhydramine, the active ingredient in most over-the-counter sleep aids and allergy medications, is an anticholinergic drug. What that means in plain language is that it blocks the nerve signals that tell smooth muscle to relax. And here is the problem. The bladder and the prostate are both heavily dependent on smooth muscle function. When you block those signals, the bladder cannot contract efficiently and the urinary sphincter tightens. For a man whose prostate is already slightly enlarged, this is like trying to push water through a pipe that is being squeezed from the outside. The flow slows. Residual urine stays behind. Urgency increases. Many men taking a nightly sleep aid are directly worsening their urinary symptoms without knowing it. I had a patient named Gerald, 67, who had been taking diphenhydramine every night for 3 years. His nighttime bathroom trips had climbed from 1 to 4 over that same period. He assumed his prostate was deteriorating rapidly. When he switched to a non-anticholinergic alternative under medical guidance, his nighttime trips dropped back to 1 within a month. The prostate had not changed at all. The drug had been the problem the entire time. 3 years of unnecessary suffering over a sleep aid. The second category is certain blood pressure medications, specifically calcium channel blockers. These drugs work by relaxing blood vessel walls to reduce pressure. They are effective for what they are prescribed for, but the relaxation effect does not stay confined to the cardiovascular system. Calcium channel blockers also relax the smooth muscle of the bladder outlet. This sounds like it should help urinary flow, and occasionally it does marginally. But in many men it causes a different problem. The bladder itself loses some of its contractile force. It cannot generate enough pressure to empty fully. Men on calcium channel blockers frequently report that familiar feeling of finishing at the toilet and knowing they are not actually finished. Residual urine sitting in the bladder becomes a breeding ground for irritation and inflammation, both of which feed directly back into prostate swelling. If you are on amlodipine, nifedipine, or a similar drug and your urinary symptoms have worsened since starting it, that connection is worth raising with your cardiologist. The third category surprises almost every man I tell it to. Antidepressants. Specifically the older tricyclic antidepressants and some SSRIs. The tricyclics, drugs like amitriptyline and nortriptyline, have strong anticholinergic effects similar to what I described with antihistamines, but SSRIs carry their own specific risk. Serotonin plays a role in regulating pelvic floor muscle tone and bladder signaling. When serotonin is altered pharmacologically, the result can be urinary hesitancy, difficulty starting the stream, and in some cases, near-complete urinary retention. I had a patient named Victor, 62, who was referred to me because he could barely urinate. He had been seen by 2 other physicians who were focused on his prostate. Nobody had looked at the SSRI he had been on for 4 months. When his prescribing physician adjusted the medication, his urinary function normalized within 3 weeks. His prostate was fine the entire time. The drug was the issue. The fourth category is decongestants. Pseudoephedrine and phenylephrine, found in most over-the-counter cold and sinus medications. These drugs are alpha-adrenergic agonists. They work by constricting blood vessels in the nasal passages to reduce congestion. But here is what most men do not know. Alpha receptors are densely distributed throughout the prostate and the bladder neck. When you take a decongestant, those receptors constrict simultaneously across your entire urinary tract. For a young man with a healthy prostate, this is barely noticeable. For a man over 60 whose prostate is already pressing on the urethra, that additional constriction can tip the balance into acute urinary difficulty. Some men experience near-complete blockage from a single dose. If you have ever noticed your urinary symptoms spike when you have a cold, it is not the illness doing that. It is the medication. And this brings me to something I want you to understand about what is happening at a deeper level across all 4 of these categories. Each of them, in their own way, is interfering with blood flow and nerve signaling to the pelvic region. And blood flow to the prostate is not a minor detail. It is the central mechanism. The prostate is a gland that is entirely dependent on consistent, clean circulation to stay healthy. When circulation is impaired, even slightly over months and years, the tissue begins to change. Oxygen delivery drops, waste products accumulate, cellular metabolism becomes disordered, and the gland begins to grow and inflame in response. This is why so many men find that their prostate problems and their erection quality decline at the same time. It is the same mechanism, restricted blood flow to the same region. The molecule at the center of all of it is nitric oxide. Nitric oxide is what signals blood vessels in the pelvic region to stay open and relaxed. When nitric oxide production drops, vessels constrict, circulation falls, and the prostate begins to suffer the consequences. This is exactly what I break down in detail in the video linked below. The research behind this mechanism is more significant than most men realize, and it explains why addressing medication side effects alone is never the full answer. Worth watching after this one. The fifth category is diuretics. Water pills prescribed for blood pressure and fluid retention. The issue here is mechanical and circulatory. Diuretics increase urine production significantly. A prostate that is already partially obstructing outflow is suddenly being asked to handle dramatically higher urine volumes. The bladder fills faster. Urgency becomes more intense. Nighttime trips multiply. Beyond the volume problem, aggressive diuresis affects pelvic circulation. When fluid is being pulled from the body at an accelerated rate, blood viscosity increases and microcirculation to small organs including the prostate is compromised. This is not theoretical. A 2023 study out of Fukushima Medical University in Japan looked specifically at what happens to prostate tissue when blood flow is chronically restricted at the microvascular level. What the researchers found was that impaired circulation was the primary cellular trigger for the abnormal growth that drives most prostate symptoms in men over 60. Not aging alone. Not hormones alone. Restricted blood flow, sustained over time. That single finding reframes everything. If you want the full breakdown of what that study found and what it means practically for men on diuretics and other medications, I have linked the video below. That is the one to watch. The sixth category is testosterone replacement therapy, TRT. This one requires precision. Testosterone replacement does not cause prostate cancer. That myth has been largely debunked, but here is what it can do. Exogenous testosterone is converted in the body to dihydrotestosterone (DHT) by an enzyme called 5-alpha reductase. DHT is the primary hormonal driver of prostate cell proliferation. When you introduce external testosterone, especially at doses above the physiological range, you can accelerate DHT-driven prostate growth significantly. Men on TRT who are not being monitored for prostate volume and PSA are running a real risk. I see this more and more as TRT has become widely available through online clinics with minimal oversight. A man named Stuart came to see me at 64. He had been on TRT through an online provider for 2 years. His energy was better, his libido had returned, but his prostate had grown significantly and his urinary symptoms were severe. He was waking up 4 times a night and his stream had almost completely stalled. He had never once been told to monitor his prostate while on the therapy. That is not a failure of TRT as a treatment, it is a failure of information. And it is completely avoidable. So what do you actually do with all of this? First, you do not stop any medication without talking to your doctor. Some of these medications are keeping you alive. That is not negotiable. What you do is go to your next appointment prepared. Tell your physician you have been experiencing worsening urinary symptoms and you want to review your medication list for contributing factors. Ask specifically about anticholinergic burden. Ask whether any alternatives in the same drug class carry lower urinary risk. Ask whether your dose can be reviewed. These are legitimate clinical questions and a good physician will take them seriously. Second, while you are having those conversations, you need to be actively supporting prostate circulation from your end. Daily walking drives nitric oxide production and keeps pelvic blood flow healthy. Morning hydration reduces urinary irritation and dilutes the concentrated urine that makes symptoms worse. Protecting your sleep allows the overnight vascular repair cycle to complete. These are the biological counterweights to what several of these medications are doing to your system. A patient named Marcus, 71, was on 3 of the drug categories I covered today. He worked with his cardiologist to adjust his blood pressure medication and simultaneously committed to a daily morning walk and proper hydration. His nighttime trips dropped from 5 to 2 within 10 weeks. He told me it was the first time in years he felt like he had some control back over his own body. What I want you to take from this is simple. Your medication list and your prostate health are not separate conversations. They have the same conversation, and you deserve to be in it with full information. Before you go, watch the video I have linked below. I know I have pointed to it several times, and I do not say that casually. That video explains the root cause mechanism connecting blood flow, nitric oxide, and prostate dysfunction in a way that makes everything I covered today fit together. It is 30 to 40 minutes long. Watch it when you can give it proper attention. I think it will be the most useful thing you watch this week. I will see you there.